session, we're moving on from potassium homeostasis and hypokalemia, and we're moving on to hyperkalemia. So I encourage you, if you haven't looked at the previous one, please go and have a look at it, because it gives you a background as into the roles of potassium in the body and how it's regulated. And then we've talked about hypokalemia. Like I said, this one is on hyperkalemia. So we're thinking about some of the main causes and some of the main consequences of hyperkalemia. So first of all, thinking about the main causes. So we're thinking about intake. Well, yes, you can get an increased intake, but really you're thinking about you're taking potassium supplements, particularly if renal excretion is impaired. Dietary intake alone seldom causes sustained hyperkalemia when kidney function is normal. So you'd be thinking you're taking potassium supplements and you may have some underlying kidney disease as well, is the most likely scenario with intake. So you're thinking reduced excretion. So we're holding on to that potassium when we don't really need to be or don't want to be. So what might that be? Well, you might have renal disease. You might have acute kidney injury where you have an acute issue affecting the kidneys, leading to reduced excretion of potassium, or advanced chronic kidney disease when your glomerular filtration rate drops and the amount of potassium you excrete also drops. So there are two things. And so you would definitely have those renal disease at the very close to the top of your thought processes when you think looking at hyperkalemia. You might be thinking about hypoaldosteronism or Addison's disease. We touched on Addison's a little bit earlier. Okay, that's when there is a deficiency in aldosterone and cortisol as well. You may be thinking some drugs, so ACE inhibitors, for example, spironolactone, which is a potassium-sparing diuretic, allowing potassium levels to potentially go up. There are others, such as your ARBs, your amiloride, for example, so they also do it, but we're not too worried about those for now. Just remember there are drugs that may reduce excretion. You've then got that redistribution. So this time we're redistributing from inside the cells to outside the cells. So it's kind of the opposite process. So you may be thinking about an acidosis. In an acidosis, hydrogen ions go into the cells, so to be buffered, so therefore potassium shifts out of the cells. You might be thinking in insulin deficiency, so therefore there's reduced cellular uptake, and likewise, and you might be also thinking about cell breakdown. So rhabdomyolysis, we talked about that, skeletal muscle breakdown, hemolysis, or tumor lysis, all of which lead to an increased breakdown of cells and the release of potassium from those broken cells. Important one for you to also just have in your minds, in particular if you're more on the sciencey realm of things, is the lab causes, and in that you're thinking about pseudo hyperkalemia. And this means that the measured result is high, even though the patient's circulating potassium is not. And it's usually because potassium has been released after collection of the blood. So it's commonly caused by sample hemolysis and can follow a variety of different things. For example, prolonged tourniquet use, delayed processing, or excessive fist clenching. All of those are potential examples. So it's important to always consider pseudo hyperkalemia before diagnosing true hyperkalemia. And again, thinking about what's the things you really want to think about, that history is really important. So you may be thinking chronic, have they got something that's indicative of AKI, so acute kidney injury, or do they have chronic kidney disease? What meds are they taking? How have they got a DKA, so an acidosis causing that potassium to shift out of cells? Has there been trauma, breaking muscles, for example, or prolonged immobility, again, breaking that muscle? So there are lots of potential things that will give you clues as to what's happening. So thinking about the signs and symptoms. So as we said before, in this case, hyperkalemia makes the resting membrane potential less negative. So that eventually goes on to impair nerve, muscle, and cardiac function. So you might be changing the potassium one way or the other, but in both cases, hypo and hyperkalemia, you're altering the nerve function, muscle function, and cardiac function. So have a little bit of a think about each of these. We did it before for hypokalemia, but I'd like you to just think about these. Yeah, just have a think and try and think about the reason for the symptom. Okay, hopefully you remember to press pause. If you didn't, we'll go through it anyway. So often asymptomatic. That's really a very difficult one for you to think about. But the reality is it's frequently detected on blood testing when patients are asymptomatic. Okay, so that might be what you're thinking in those. So it's the result may first be identified just on that routine testing. Muscle weakness, well, again, you're getting impaired neuromuscular function. Reduced reflexes, reduced nerve and muscle excitability, reduced weakness can occur in the respiratory system, in particular in severe cases. And again, you've got your cardiac arrhythmias due to disturbed cardiac function. So not particularly challenging, lots of overlap with hypokalemia. Just the mechanism is slightly different because you've got different excitabilities. And with the ECG changes, just if you're thinking about those, again, you may get your tall peak T waves. We talked about that a little bit earlier at the beginning of the session. You may lose P waves. You might get widened QRSs, and you may get ventricular arrhythmias in severe cases. So it's just, but it's also important to note that the absence of classic changes does not make a raised potassium safe. So don't just think, oh, they haven't got any of these classic signs or symptoms. That doesn't mean it's safe. It still needs to be addressed. So how do we evaluate? Well, just like we did with hypokalemia, the first assess the potassium concentration, the symptoms, and the ECG, because it's really important that severe and clinically credible hypokalemia, that does require urgent assessment. So that's the first thing that's done. So again, now we've done that, what's urgent and what's not, and we're going to go and look for that obvious cause. So starting at the top, up at number 1, so we're thinking, is there an obvious cause? So have they got chronic kidney disease or AKI? So have they got severe hypovolemia leading to AKI? Have they got well-known chronic kidney disease, for example? Are they taking potassium supplements? Potassium supplements, potentially, sorry, in line with a chronic kidney disease. Are they taking some meds that may be leading to hyperkalemia? And then we've got potassium intake but we're thinking about that as supplements because it's very hard to take too much potassium otherwise, and thinking about kidney disease with the two linking together. So just like before, an 80-year-old woman presents to ED with severe dehydration and reduced urine output following several days of vomiting. So what's happened? She's lost severe blood volume. She's got severe urine output decrease. She's probably entering into acute kidney injury. And so that's what we're happening there. It's what is happening in this lady. So could potassium be shifting out of cells is the next thing that you look at. So you might be thinking about the acidosis, insulin deficiency, or that cell breakdown, so that we talked about. So you're thinking rhabdomyolysis, tumor lysis, and hemolysis. So thinking about the case, a 67-year-old man presents to ED with fever, hypotension, and confusion. So this is looking now like they may have severe sepsis in this case. So, and that can cause a metabolic acidosis. So how does it cause that acidosis? Well, you've got severe sepsis causes systemic vasodilation. So therefore, there's a drop in blood pressure and a lack of oxygen going to tissues. So they start to work anaerobically, driving a lactic acidosis. And that acid shifts into the cells, meaning potassium shifts from the cells into the extracellular fluids. So that's what's probably happening in this 67-year-old man. Next, bicarbonate. Remember, that helps to identify an acid-base disturbance, but it does not provide a diagnosis. And some of these we've touched on a little bit already. So you could be thinking if there's a low bicarb, so you're thinking a metabolic acidosis, you might be thinking DKA, renal failure, or sepsis. Bicarbonate might be normal in early CKD. You will get an acidosis in later CKD. You may have pseudo-hyperkalemia, or you may be thinking about some of the meds that we talked about a little bit earlier. So what's happening in this person? 23-year-old woman presents to ED with abdominal pain, vomiting, and suspected DKA. So remember, insulin normally moves potassium into cells. In DKA, a lack of insulin and the associated acidosis could cause potassium to shift into the bloodstream. So that serum potassium may be high, even though the body has lost significant amounts of potassium in the urine. Remember, with that osmotic diuresis due to the hyperglycemia, that a patient with DKA will have. 36-year-old woman attending a health check has an isolated raised potassium but no symptoms. So what are we thinking there? Well, we're thinking an isolated, unexpected result in a well patient should prompt examination of the sample and, where clinically safe, urgent repeat testing. So you might be thinking about pseudo-hyperkalemia, which is the last step there. Could this be pseudo-hyperkalemia? Well, it looks like it. So most true hyperkalemia results from reduced renal excretion. So you're thinking chronic kidney disease, which is very common. You're thinking acute kidney injury as well. Could also be down to a variety of medications. So we've given some examples for you there. Or release of potassium from cells. So you're thinking about potassium shift. Those are the ones that you really be thinking about. That acid-base status and pseudo-hyperkalemia come a long way down that kind of list. Okay, so another little question for you. I'd like you to press pause, read through the question, and try and answer the question. A 60-year-old man with stage 3 CKD is brought to the emergency department after falling down the stairs and remaining on the floor overnight. He's marked muscle soreness in both legs. So let's have a little look through these serum findings. So potassium is elevated, sodium okay, chloride okay, bicarb okay, urea is elevated, creatinine is elevated, and creatine kinase is very high. So the question is, which process is contributing most directly to this patient's hyperkalemia? So what do you think the answer is? And what are the clues? Well, that creatine kinase is very, very high, and that CK has obviously come from his skeletal muscle following a fall and remaining on the floor overnight. So he's got severe muscle damage, severe loss of muscle tissue. In essence, the muscle cells have died, released lots of potassium into the blood, causing that hyperkalemia. But of course, this patient also has got chronic kidney disease, which also leads to hyperkalemia. So, but in this case, it's relevant because it does reduce the patient's ability to clear that additional potassium load, but it's not, it's stage 3. So severe hyperkalemia in itself isn't going to be happening at stage 3 or not in the early stages of C3, stage 3 at least. Maybe late stage 3 into stage 4, you start to see a hyperkalemia. The key thing is, got hyperkalemia and he can't clear it because the kidneys cannot, their GFR, their filtration rate is dropped. He can't clear it effectively. So could we diagnose acute kidney injury? Not really, not from this creatinine and urea alone, because we haven't got a baseline in this case. So you could be thinking acute kidney injury because myoglobin, which is also released from skeletal muscle, is nephrotoxic and can lead to acute kidney injury. So there could be acute kidney injury here, but you can't diagnose it. You have got that high potassium, so the most likely reason is from those muscle cells. But again, like I said, this could be leading into acute kidney injury as well. We don't know at this stage. Okay, that is the end of the session.